Throughout the COVID-19 pandemic, poor working conditions have exposed weaknesses in our healthcare systems, which threaten not only the people that we care for in institutions, but really the health workers' fundamental right to health. Healthcare workers in their everyday work, and especially on the front line globally across the world in COVID, their response has been supported in unparalleled workplace pressures. And we have to really look today at workplace discrimination, which includes ageism. The WHO back in April this year, talked about 3 particular areas as it related to health workers: COVID-19 infections among health workers, violence and stigma against health workers, and long working hours and psychosocial hazards for health workers. And what struck me where I live in Ontario is that partway into, the most serious part of this pandemic in Ontario, when literally hundreds of people were dying in nursing homes, we heard the call of those that had retired from the industry to come back in. And it seems to me that we really need to unpack this paradox. On the one hand, many times older people are asked to retire, and then when the time gets tough, we ask them to come back into the workforce. So we're in conversation today with Susmita Sinha, founder and president of the Health Law Institute in Geneva, Switzerland, and during the course of the conversation, we're going to explore the impact of ageism in the health workforce and good practices in safeguarding the well-being of health workers. And I've got into the habit of saying that we're going to be living with COVID, and that is the reality. So whether we have a vaccine or not, as we live with pneumonia and influenza and shingles, etc., we will be living with COVID throughout our lifetime. Susmita is, as I said, the founder and president of the Health Law Institute, and she's got a fascinating background. Her professional experience is as a pharmacist and a lawyer, and it spans both the public and private sectors in different geographical locations. Susmita has lived for 18 years in Nigeria and really regards this as a place to call home. As well, United States and the United Nations in Geneva are also places of her residence and where she spent a lot of time exploring, professional portfolios. She's a person, as you would imagine, that speaks multiple languages and is passionate about health worker rights, universal access to healthcare, and advocates health workers as key actors in health system strengthening. And before I just hand over to Susmita, I just want to acknowledge Xenia Shiel Adlang, who is one of the IFA representatives in Geneva, but also the Vice President of the Health Law Institute. So welcome, Xenia, and I hand the floor over to you, Susmita.
Thank you, Jane, for that introduction. And thank you all for tuning in to hear me. I had the opportunity to hear Jane at the Human Rights Council in Geneva. I was touched on how she was able to relay personal struggles so openly and yet objectively view it and make a call for change on a human level. Jane, you're truly a remarkable person and leader, and I'm excited to be here today. I feel the IFA Town Hall seems to be reflective of this spirit. In a time like this is an amazing initiative. It helps to keep us connected, focused, and curious. For many issues that are not usually visible or intentionally or inadvertently overlooked, I think this dialogue is an effective tool to understand the issue, its precipitating and enabling factors, and help to collectively figure out solutions. The pernicious problem of ageism in the workplace is one of such topics, and even the health workforce is not immune from it. There's a lack of research and reporting. In fact, the High-Level Commission on Health, Employment, and Economic Growth that was set up between the ILO, WHO, and OECD a couple of years ago to take a comprehensive look at health workforce sectors in order to address the inevitable shortage of health workers we're supposed to face, did not take into account ageism and its ramifications on achieving a sustainable workforce. I'll highlight areas of ageism that I have been privy to through colleagues and from some of the research done at HLI, how COVID has impacted many of these concerns, and would like to wrap up with some of my reflections and open it up to questions, information sharing, and suggestions. The stigma and discrimination older people may face from the health system is a known problem. Currently, we also see a disregard for the lives of older people who are more vulnerable to COVID. However, how many of us have actually thought about what older health workers are facing at their jobs? As our population ages, so does our workforce. For example, in the US, according to the American Medical Association, nearly 150,000 US physicians 65 or older are in active practice. That's nearly 15% of the physician workforce. In general, health-related jobs are inherently stressful, especially the patient-facing ones. It requires both personal skills and technical skills. Health professionals have to deal many a times with life or death situations, the emotional encounters they have with patients and family members, the challenges and stress of providing care and trying to save lives, and sometimes even very gruesome scenes. And one of the main effects of this is burnout. In recent years, we've been hearing more of this, and the situation is progressively deteriorating. As individuals spend longer times in this profession, it not only increases the risk. For many to continue this work, they internalize the fact that this is normal and push themselves to work, leading to harmful physical and mental health issues. Another related and maybe much less discussed and documented concern is abuse and violence. Unfortunately, abuse and violence is part of many healthcare jobs, and the ageist attitudes of patients, coworkers, management can make it more traumatic for older individuals and create a hostile work environment. Adding to this intersection is gender, race, ethnicity, and disability. Further, many a times the work environment is not always suited to the needs of older people. As a pharmacist, especially in the chain I practice, we were required to stand for the entirety of our shift and could not have a stool near our terminal. One of the pharmacists who had been practicing for 50 years, this became quite a challenge, especially as many of the stores started transitioning from the regular 8-hour shifts to 12-hour shifts. He did request the management for accommodation and was denied this. And this was one of the factors that finally, led him to decide to retire, though he was really capable of carrying out all the required pharmacist tasks. I'll give a shout out to Walt, who I'm referring to in this previous example and is listening in right now. Shifting to nurses, this also requires a fair amount of patient mobilization, which can be aggravating for older nurses. The usual recommendation is that nurses and caregivers should not lift more than 35 pounds without an assistive device. If you think about that, that's nearly most patients. As the population becomes progressively obese, this escalates the problem. There are technological advancements and equipments like overhead lifts or motorized hoists, but sometimes the cost or even the inadequate distribution protocols in institutions can prevent older nurses from access to them. As people age, our health requirements change as well. For example, there was a recent article about female doctors battling with menopause. Because of not being understood by the management or coworkers and not being able to speak up, it could be because of a fear of gender bias that already experienced, or they realized it would be damaging to their career progression, they kept struggling to cope with the menopause symptoms with no support from management or peers, and finally decided to retire early, reduce their hours, or move to lower paid jobs. Even if all these factors I mentioned did not exist, sometimes changes and advances at the workplace do not allow for correctly assessing older people's usefulness. For example, a number of years ago when we had advances in technology, like a rehaul of the entire system that came up during electronic prescribing, electronic health records, or using connected devices to take session notes, this was a difficult process for many older health workers. I personally noticed that the interaction time that I used to have with my primary care physician was reduced as she was struggling with screens and having to choose appropriate responses. And in many cases, this led to the assumption that older people cannot cope with technological advances. But the reality is that there isn't enough institutional resources, both in support and budget, invested into employees, helping employees make this transition. And inevitably, this can lead to older health workers being left out of promotions or career advancement. In addition to this lack of enabling environment, as older people progress through their careers, there's a lack of clarity on how they might transition into new roles that could benefit from their experience. A lack of innovative approaches or other organizational factors prevent health systems from harnessing the strengths that older people bring to the workplace and keep them part of the health system. In the medical field, there's also a changing pattern of employment relationship. And I think this is in many other fields as well. We have temporary workers, we have part-time positions. One of the reasons is certainly the cost cutting by organizations. But sometimes this is also initiated by the employees themselves. More and more older women are filling in for the shortages of long-term care of family members. And as we talk of career progression, we invariably come to retirement. In many countries, there are mandatory retirement age policies, and in many cases with gender disparities, women are forced to retire at an early age than men. And taking this a step further, you have discriminatory screening. For example, you have cognitive and eye exams to maintain hospital privileges in many countries. One of the reasons that's put forward for this mandatory retirement age caps or discriminatory screening is patient safety. But we have to understand that older people is not a uniform group. Therefore, what we should be really focusing on is functional limitation and how to determine this in a non-discriminatory and non-invasive manner. Earlier this year, in a case against the Yale New Haven Hospital, the Equal Employment Opportunity Commission in the US held that the health system had actually violated the law by requiring employees to complete this cognitive and eye exams to maintain their hospital privileges. On the flip side, if you consider the intensity of frontline health worker jobs, should they be treated similar to other professions that are equally rigorous and require top success rates? For example, pilots or police or firefighters have the option of early retirement with the ability to access full pension. Till date, this is not the case for health workers. With this in the background, we have the advent of COVID. As Jane mentioned, to start off, there was an appeal for retired health workers to come back to work. In the UK, nearly 11,000 former medical staff have returned to service. In New York, 40,000 people signed up. I do believe that for many, working in the medical field is a calling than just a profession, and one of the reasons that we've seen such an outpouring of people coming back to health. We have seen COVID exacerbate burnout. In many cases, health workers have reported to being pushed into situations akin to forced labor, as in working without breaks, without vacations, or time off. There has been an escalation of stigma and discrimination against health workers because many fear they're infected. Attacks against Asian health workers is definitely on the rise. I have not seen any particular account that took into consideration the health worker age, but in a recent article that looked up 20 countries with the most coronavirus cases. in 9 of these countries. So US, Spain, Italy, France, Germany, Canada, Belgium, Switzerland, and Portugal, more than 30% of the physician workforce was over the age of 55. In Italy, which was one of the hardest hit, the majority of physicians are over 55. We know that older persons are more vulnerable to COVID, and even more so when they have pre-existing medical conditions. We have heard about the shortages of personal protective equipment, putting health workers at risk, and also the subsequent patients they will treat. So we're led to question if we're sacrificing older health workers. This lack of PPE, trainings, and the protocols to ensure safety is worrisome. Not even to mention hospitals that banned individuals from bringing their own masks when there was a shortage, or disciplining employees from wearing it in the hallways. And this is not just among physicians, nurses, pharmacists, and other licensed health workers, but includes support personnel like cleaners, administrators, technicians who come in contact with patients and other front health workers directly or indirectly. It has been reported that 19% of confirmed cases in the US have been health workers. In the UK, 1/3 of the National Health Service staff and key workers tested for coronavirus have been confirmed positive. The CDC publishes the cases and deaths among healthcare personnel. As of yesterday, we had 132,078 confirmed cases and 624 deaths. Of course, this number is reflective of the availability of healthcare personnel status, which many times might not be reported. Many sites, Facebook and Twitter accounts, professional groups have been posting about health workers who were lost to COVID. However, none of these, to my knowledge, have been disaggregated by age. These gaps in data and even literature on older health workers keep this an invisible problem and not allow for us to take steps in rectifying it. Mental health has also been a concern among the general population and health workers. For older health workers in particular, I cannot even fathom the effect on mental health. In addition to what all other health workers face, I wonder how they're coping with blanket resuscitation orders, where they're forced to withhold treatment and equipment from older patients. The moral injury caused by those decisions are already grave, but I have pondered if the fact that this is how they would have been treated had they been the patient causes them additional distress. And one of the things we cannot overlook during this pandemic is the lack of freedom of assembly for health workers in many countries, or even differences within a country. Is the fact that health workers cannot unionize in many countries leading them to be trampled upon and not afforded the basic rights and safety afforded other health line workers? For example, in the current debate of reopening school, there has been a talk of teachers' unions striking if they're recalled back. In fact, many teachers have decided to retire, then go back. There are a host of other challenges, but I'll wrap up for now with a few observations. COVID has given us an opportunity to see that older health workers can be integrated into the system. And one of the things Jane touched on, and I think it makes us really question whether these health workers should have been retired in the first place, especially given the shortage of health workers we're bound to face. I think it's a no-brainer that we really need to make space in our workplaces for accepting more older people and providing for their safety and career advancement. And to do this, we really need a rehaul of the system, right from education to training, to hiring, career development, and service delivery reforms. We need to look into practices that lead health workers to retire. We need to formalize positions for older health workers, whether it's in terms of pay and benefits, that have already come back to work. Making it easier for older people to avail protections provided for under anti-discrimination policies, programs, and laws. And important to take into account the life course of individuals to ensure realistic expectations from health workers. Additionally, as I mentioned before, we have to be cognizant of balancing patient safety with health worker capabilities. But we have to evaluate how to do this in a discriminatory or non-discriminatory or invasive procedure. Also, creating an enabling factor through leveraging technology and starting off by gathering input and feedback from health workers and supporting to make the change is essential. We need to start considering options for early retirement with full pension, given the rigorousness of the jobs. And lastly, even to explore avenues how to allow freedom of assembly and social dialogue for health workers. I'll end on that and I'll hand over to Jane.
Thanks, Susmita. And what you've done is really given us a lot to have a discussion about. And while we are, and thank you, what comes through is your broad professional experience, but also the personal experiences. So I encourage, as Andra has just done, 4 questions, but I've just got one question. Right at the beginning of your talk, you talked about an enabling environment. And we often talk about this in the context of age-friendly environments. We talk about how do we create an environment that enables older people to do what they value. And in fact, perhaps we should be thinking about how do we create the work environment that enables people of all ages and at all times in their life, to contribute, as you've mentioned. So could you just make a comment about that? And then I'm going to ask Eileen from Ireland and also Kanwaljit from Singapore to come forward. Would you like to just make a comment?
Perfect, Jen. Yes, I think that's a very interesting outlook. And that's what we have to understand, that healthy aging does not always just start at old age. It's actually through the life course. And you're right. And that's why we need to have an enabling environment that's both from the youth, from when they start, right to older persons in the health workforce. And we have to leverage that. So something like burnout, it's a progressive thing that happens over time. It's not that just when somebody hits a certain age, it happens. It's throughout. And trying to minimize things like this, creating, or one of the examples I'll bring up, as a pharmacist, we really did not have a lunch break. We routinely, tell patients that make sure you're eating your food on time, make sure you're doing that. You could have acid reflux because of this. But most pharmacists, and in most of the chains, don't get a lunch break. It's only just in the last couple of years this has happened. So progressively, your health is deteriorating, and this doesn't lead to healthy aging. So I think all the, many of these things that I'm talking about really needs to be put in place, and we look out for them. The other thing that I mentioned is the whole career progression. As an employer or a supervisor, one of the main things should be that we're preparing our staff to move towards, moving into other roles, and being supported to do so starts right from an early, period, right from when you start the mentoring as an intern and moving up to senior leadership or actually leading. So you have the good practices built in place to get to that.
Okay, I think we better kick on to questions. So Eileen Kanwaljit, and then Kathleen Brasher wants to make a comment. Okay. So over to you, Eileen.
Okay, thank you very much. It's brilliant to hear age discrimination being considered in the context of the working environment for healthcare workers and older people in particular. In most countries, there is in European countries anyway, age discrimination is outlawed, even though individual contracts can have a fixed age in which people give up their occupation. But if an individual challenges it and it has to go through the EU legislation on age discrimination says, yes, you can have age discrimination if it is justified as a legitimate aim, as a means to achieve a legitimate aim. And some of those are occupationally specific. So that is for all occupations. And really it should be for healthcare workers as well. Throughout the life course, there are certain conditions in employment. But what you're also highlighting is that if older people are in a workplace during COVID, they see the situation where if they were a patient, how they will be treated. So there's ageism also for patients in the healthcare worker. So it's going right through the system and fundamental. But ageism is one of these things that everybody accepts as a form of discrimination. So it was great to hear your perspective, but I think we need to do more about it. Thank you.
All right, thanks, Arlene. Kanwaljit from Singapore, you have a question.
Well, it was more of a comment. What I meant was, we hear of all the problems that older healthcare workers have to face. And I'm a practicing orthopedic surgeon who's 78, and I haven't stopped working yet. Now, what I wanted to add was that older healthcare workers can also bring a lot of added diversity and create an intergenerational workforce. And this will help productivity. It'll help to share experiences. So besides facing difficulties and challenges, older healthcare workers bring a lot to the ecosystem.
Okay, thank you. Kathleen.
Thank you very much. And thank you, Ms. Sinho. You raised so many points. It's hard to choose just a couple to ask your advice on. But when you spoke about older health workers sometimes struggling with technology, what came to mind for me was the great wisdom that often older health workers have, and that technology forces this compartmentalized knowledge and prevents us from bringing the holistic understanding that we have about caring for our patients. So I was wondering if you can speak a little bit about how we capitalize on that great intrinsic knowledge and wisdom that older health workers can have, and the constraints in some ways of working with technology. And the other comment I wanted to make is I live in Victoria in Australia, and we're in stage 4 lockdown again, with most of our deaths in aged care, and a large number of health workers testing positive and being greatly affected by COVID. The publicity has been while certainly there's been acknowledgement of the deaths in aged care, and quite respectfully and appropriately, but the impact on health workers, the focus has been on the young health workers and the impact on them, and the extraordinary contribution, as Jane mentioned, of older workers coming back out of retirement to support aged care workers just doesn't get any publicity at all. So there's a media or a publicity bias towards young workers as well. So I was just wondering if you could perhaps speak to both of those.
Yes, Major.
Perfect. Thank you, Kanwaljit, for your service. That's really, to be in the practice, I think that's great. And I think those are really, added points. And for the health workforce to actually harness some of those trends is what's needed. And this requires not only, the budgets on the institution to really work with health workers to understand these trends, but also find new roles where you can, because not all health workers, and I think older people want to tend to be mentors, but they want to feel other roles they can, whether it's moving into administration, moving into other things. But the intergenerational workforce does have a lot of strengths. Eileen, you're perfectly right. I know that in EU, is it the Employment Equality Framework Directive does combat ageism, but there's definitely more that can be done. And sometimes for many of these cases, even in the US, it might become very harder to prove And that's what makes, ageism really difficult. It's creating that environment and really having, the kind of things that are required for a legal case to come up can be quite a lot of hurdle for many people. Kathleen, thank you for your question on technology. I do think, technology is an added tool. The experience of the health worker really does determine how good they're on the job. And I'm trying to remember, there was a study done, I think, for physicians. I'm trying to remember if this was Colorado. I can try and look it up. But I think what they tried to do was having an assistant given to physicians who'd actually take these session notes from them and kind of compile them and put it together so the physician themselves could spend time directly with the patient. And though initially it looked like this was taking up more finances and budget to do it, they found out that they were actually able to see more patients. And I think there was more patient satisfaction because they were getting more, the patients were getting more time from the physicians. It had better outcomes. So I think that, it's really looking into it. It's putting that investment into finding out that it works. And as I mentioned, that's the thing, the literature that's out there, there are really gaps in it. There's not enough research on that. For younger health workers getting more attention in the media, I've actually heard both, but I think one thing that has come into focus is a lot of programs that have really fast-tracked graduation so that, younger health workers can start contributing, even if it's minimal roles. I personally have not heard like a difference. I have been hearing also like where older health workers and the focus on it. So I could not really speak directly to it, but it would be something to discuss more or actually find out if there was any particular one that you felt that there was more of a focus on the youth. But I know the fast tracking of medical graduates was a lot in the news because it was trying to add to the workforce and trying to get them roles they can fit in and help out with the system. But I think there has been a lot of articles, whether, for the US, Italy, UK, where we have seen older health workers retiring. And the fact that they are vulnerable. Some of the things that have come up are the good practices that we can have for older health workers coming back from the workforce, whether it's moving them to administrative roles where they're not like patient facing, but we can really still tap into their experience. Using telehealth is another avenue that you really can, keep the older health workers safe, but still harness those skills. So just to mention a few.
Thanks, Nita. I also want to just salute Kanwaljit from Singapore. It's inspiring what you said. And I think it's also inspiring that you made the link to intergeneration. So thank you for being on the call. I also want to acknowledge Kathleen being in Victoria, the state of Victoria, and my country of origin, Australia. And it's so very difficult to have seemingly contained the virus for it to only be almost exploding again. And so I want to acknowledge, Kathleen, that Victorians are very much in a lockdown situation and trying to contain, COVID. We have 3 more people to provide questions to you, Susmita. So we go to, and please forgive me, I'm not going to pronounce these names appropriately, Maud Irfan, Kathy Klein, and Vijay. So Maud, are you with us?
Sure. Jane, thank you very much. I wondered, based on what you had said, all of you, about the workforce and the importance of including that environment, whether ILO has any kind of formal partnership with the WHO so that age-friendly environments could actually extend into the workforce officially? Thank you.
And perhaps for those, ILO is the International Labour Organization. We'll just go to take Vijay's question. Vijay, where are you? Yep, unmute yourself, we're nearly there.
Okay, thank you very much.
Good.
Yeah, I very much appreciated the proposal that the options for earlier retirement with full pension. Unfortunately, here in Mauritius, we are running the other way, the opposite way. In the last budget, it was proposed that older people would be encouraged to retire because the economy is at its tail. There's no production. The main sector, which is tourism, is zero activity, and there is no production. So even in the textile factory, which are not operating to the extent that they were operating before, so people are encouraged to retire earlier than to stay. So we don't have a robust economy which would be able to sustain this proposal, that is, retain them or let them go with full pension.
Okay,
Thank you.
Vijay. So Kathy and then Vijay, Susmita.
Okay. Kathy, to your question, one of the initiatives they had was, as I mentioned, was between ILO, WHO, and OECD. And this was the high-level commission. And I think the commission nearly 17 studies to look at, the health workforce in many different, whether it was for hiring, the actual economy, and then, like looking into other practices that do it. And from what I have seen with the high-level commission, ageism was not one of the initiatives, that was looked at. It certainly looked at how health workers would work with the aging population, but I think aging health workers themselves is not. I know we have Zeni on the call, who I turn to with her expertise in ILO. So if she's there and she wants to put into any other suggestions, I'd be open to it. But to my knowledge, I think they kind of overlooked that. And that was one of the things that I think we really need to, because this is a 5-year plan that comes from it and many of the initiatives that go into health workforce. We know that by 2030, there's going to be 18 million shortage. And there has been a lot of talk about how do we make, social accounting education programs, how do we actually use the skills of individuals. And I think on that point also, we've heard a lot of position of, people are overskilled for a certain position. And I think this itself has connotations of ageism in it, where we find that somebody's overskilled, so we don't have certain job sets. So I think it is one that should be more looked at. I personally am not aware of initiatives, but I'd love to look into it more. And if Zenia can offer any more suggestions on this. To Vijay's, I hope I got the name right. I thought it was Vijay from Mauritius. It definitely, this is one of the things we keep hearing, that the economy cannot support it, our budget cannot support it. But one of the greatest realizations now that we have had during COVID is that if we cannot protect health, it affects the economy. We have seen our economy tanking. And I think for years we've been talking about how the right to health is a multiplier right, how it affects many other rights. And this has kind of shown how it has impacted finances. So it might be difficult to see how, putting in more money would actually help us in the long run, but something that can be done, that should be done. I think over time, there has been in healthcare itself, and I think that's why we have had a lot of the shortcomings during the COVID responses, has been a differentiation of public health, social care, and actually responding to healthcare, so acute needs. And this has fragmented over time. And what we really need is more of a response that talks to all these 3 areas. And the only way to do it would be actually to look into these things where we can retain workers, we can have healthy workers, we can have productive employment. So I do believe that right now it's not something that's in place, but having the experience we have had with COVID, and this is not the last pandemic, we're still going to have other public health crises. We need to start putting that in place. To figure out how to do it, certainly that falls into health financing and the policies that we put in place.
I wonder, Susmita, just speaking to this, that, we often talk about the fragmented nature of those that are concerned with older people and to bring together. Is there an overarching body that brings together, the WONCA, the World Medical Association, the pharmacists, the care workers? Because it seems to me that unless we're actually speaking around professional associations with one voice, to the WHO, and then to at a country level, then we're actually not going to be moving forward. So I'll just leave that with you for a moment and call on Mark Venning. Welcome, Mark.
Hello.
Yes, we've got you.
Actually, my comment was around what does this all say about leadership in organizations, that all this stuff is going on? So that's number one. And number two, what's the reaction around what do we say about attracting and retaining talent going forward if all this ugly stuff is going on? So what do we do about that?
Okay, thank you. Over to you, Susmita.
I think you're certainly right, Jean. Working in silos does not help, anyone. And over time, but it's kind of a balance. What happens over time, you start off in an area, you start forming things and guidelines that work with it. And I think silos are formed really because people get specialized. But without having that communication, whether it's between NGOs, intergovernmental organizations, and even institutions, this is a hard one to work with. And I'm hoping that this will be like a call out to them. Even in the health profession itself, you do have the World Health Professional Alliance that brings in a lot of the health workers. But more and more we're seeing community health workers that can deliver care, long-term care workers. And I think having that overarching body to work on that is important, not only for the aging population, but I think the population at large. But being equipped for the aging population is definitely something that needs to be worked on. I'd be happy to talk about this further and how maybe, building those bridges and actually the information sharing and working on initiatives together is definitely needed.
It seems to me that, there could be the World Health Professional Alliance, but aging organisations are not part of that. And so they're talking to each other.
Exactly.
Very unhelpful. It's really my staff are going to laugh. It's the intersectionality, that we need to create. And, and we go back to Mark's point about leadership. Who's doing it? And I look around and it needs to be us. And what does that look like? So perhaps you can respond to Mark's point as well.
To that point, yes, I think you're right. It is something, it would be great if IFA took that initiative and include everyone and do it. But, it is a big initiative, but I think certainly one that needs to be done. And one of the main things is leadership. Leadership can be in different levels, whether it's of the country, whether it's the institutions. I look from the institution perspective. What we've seen that in the countries that there were good practices, or in the institutions that there were good practices, it came down to 4 things. One was mitigating local transmission. If that meant limiting the people entering the healthcare facility, reducing staff to essential personnel, screening all the people that are entering the facility. These were many of them, following the IPC guidelines, the infection prevention and control guidelines. The second was conserving, protecting, and supporting staff. Definitely lack of PPE or conflicting protocols that came out at different times on what should be used affects that. We've had incidences where many chains, I know pharmacy chains that were doing mental health apps for their employees to help them during the situation, and they could sign up. So that's protecting and supporting them. The third thing is eliminating non-urgent strains on the system. So they prioritize essential care. This can go both ways. Certainly we need to take care of it. I think in many countries what happened that some hospitals got assigned to be COVID hospitals. So we could remove the other population from it, not expose them to the risk. Many of the times they were doing testing outside the hospital premises before moving in. So you kind of kept patients or other people safe. So things like that. And the last one was communication. So communication from the senior leadership to frontline health workers is so important, especially in a pandemic or any public health crisis. There's a lot of fear that comes with it. there's a lot of these protocols need to be in place, and clear communication, I think, was one of the hallmarks of good leadership. I have talked personally to a lot of pharmacy technicians and pharmacists during this time, and one of the hardest things was that they were not hearing anything from their supervisors. They did not have their supervisors tell them, and for many, I think almost March getting into April, there were a lot of pharmacists, the supervisor had not talked to them, they had not been provided masks, there was, forget gloves, there was no, disinfectants going on, and they were still not limiting local transmission. So they would have people come into the pharmacy and actually wait in the waiting area. And many of these pharmacies had drive-throughs where you could really go ahead and have people just come in through the drive-through to minimize exposure. So I think communication would be one of the biggest thing, and it's from communication that you can put into place many of the other policies and programs that's needed.
Could I also suggest that, respect needs to be the thread? Because, what I'm seeing also is that there's almost a given. Well, the care workers will they'll do it. But we actually don't, we legitimize that that's their role, but that's their role, isn't it?
Yeah.
And my concern is that after, we've had the spike and we're down the other side, but we're still working, in this very difficult area. I'm not sure that we're giving each and every single person the same respect. And I think about when I used to work in acute care settings, the housekeeping duties, the domestic duties, the cleaning duties were actually important, if not more important, because they often knew a lot of what was going on with the patients. So we need to sort of, the way that I'm thinking is we need to almost, stretch our band of healthcare professionals who is in touch with that person in the bed and their family. Because otherwise we get a very tiered approach of who is the legitimate healthcare professional. So do you have any sort of comments? I mean, I know it's a bit of a loaded question, but you have got me thinking.
I think that's been in debate for a long time. What do you classify really as a health worker? And I think WHO does have guidelines on what they have tried to follow, because it's very difficult to look at it. What you're talking like a support personnel, a cleaner, is definitely related to it. So are a lot of lab technicians that work on it. And then the frontline health workers, you have licensed health workers, you have non-licensed health workers, you have people that have come out, the community health workers that are trained to do it. So there is a lot of gray areas. But, I think the main thing is that it's anybody who's involved in the care of a patient or the health, and that's how it defines it. I think this is from the 2006 report. But you're right. I think expanding, the horizon is important. We have seen, and this was some of the research that Xenia had earlier done, about how one health worker jobs actually creates in most countries 2.3 other non-health worker jobs that are related to it. And in low and middle income country, this becomes even more pertinent. I think one health worker job actually creates 3.4 non-health worker jobs. So I think that's very important. And the main thing, especially with the pandemic, is the contact tracing. So you're right, is really knowing where, who did this person come in touch with? And sometimes support personnel get forgotten. The person who has done the triage, somebody who has actually admitted them, who's keeping the files, but might be talking to patients and going out. And these are things to keep in our mind, like where should we expand contact tracing to?
We've got lots of discussions going on in the chat box. I just want to acknowledge Kelly Kay for her sort of involvement, and also Jean Bank. I know that Kathleen's put some resources in there. So Andra's going to be gathering up all the chat box. We've got one last question from Francis Zanadin. So Francis's question was, is there any information on the informal care sector, including home care workers who are often less trained and I would say less poorly paid, are they considered healthcare professionals?
There are definitely health professionals and they're providing the care for it. We actually, on our website, we had a blog where we looked at community health workers and many of the places, countries that had been able to use this. I think South Africa was one that was very easily able to provide health workers for PPE. They actually went door to door and looked for COVID patients. And this actually worked in two ways. One was the outreach they had, but also the, prevented exposure of other people to come to the hospital. I think Rwanda was another country that had nearly 60,000, community health workers. In India, the ASHA program was another one that, did take this up and look at it. So I think there are definitely, a lot of initiatives, and I think it's an area that can be expanded more into, as I mentioned, like we have this whole, and community health workers come from the community. So they're part of that. There's a lot more buy-in from people. Certainly it's also reflective, but the main thing is actually protecting them and getting, having definite protocols where they can help. But there is a lot of opportunity in what can be done and the benefit that we can have from it. So that's a really good point, Franz.
Yeah. Susmita, I'm just going to ask you a bit of a curly question.
Okay.
Right, so IFA, one of our priority areas is improving the uptake rate of adult vaccination globally, because the uptake rates of, influenza, pneumococcal vaccines is very, very poor across the older population around the world. And as we start hearing about, the COVID vaccine, it raises a lot of questions. But one area which we should be very concerned with is the very poor vaccination rates of healthcare professionals. Very poor, generally across the world. Right? So I guess my question is, how do you see, if the vaccine is here for COVID, what responsibility do healthcare professionals have in getting that vaccine? And you don't have to answer it, but it's an important question.
No, I think I just wanted to clarify, when you meant there was less, did you mean health workers themselves getting vaccinated or being able to provide it?
No, healthcare workers generally around the world have a very poor uptake rate of influenza vaccination, for example. It's a great worry, as you would imagine. So we're coming into this new sort of era of potentially a COVID vaccine, and it's a real problem, isn't it? So we could have healthcare workers that are not vaccinated actually going, being the formal carer professional for those who are most at risk.
I think I'll be the devil's advocate and call up herd immunity because you're exposed to other people, but that's not it. I do think, I'm not aware, and I'd love to really look into more of the data that shows that, because that is an area of concern. And in fact, one of the things when, I came up with, there was like a 10-point agenda we had at the Health Law Institute of what should ensure and what we should ensure. And one of the things was really priority testing and preferential, access to vaccines for health workers. So this is something I'd love to discuss further and see if this is what it is. I think from my experience, I know in pharmacies, pharmacists started moving in the US, we started doing vaccinations, which actually increase access to vaccine, and we would get, you could get vaccinated. So I personally felt that the fact that the vaccinations were given in the pharmacy made pharmacists take the vaccinations more often. I know that a lot of people have allergies and that could affect it. But yeah, I would love to look at that data and see and why that is so. And, this would be very important, because I think healthcare professionals not only have a duty to themselves to be protected, but also to their future patients that they're going to see. This poses a risk. I mean, so I'd love to talk about that more.
Right. Well, perhaps we'll have you to come back to talk about, healthcare workers in low and middle income countries. I think that's an area that we'd really like to be interested in. And also I think there's time in the future to start talking about, you know, allocation and access of the COVID vaccine. Where do older people fit in the range? So I'm just going to wrap up, and then I'm going to come back to you, Susmita, with your takeaway message. Okay. So, you know, this was a very jam-packed session. So we thank all of you for being. Some of the key words that I took away was that, you know, in this situation of COVID, you know, we're recognizing burnout, and yet it's really been with us, you know, ever since health professionals existed. And we have an opportunity, surely, for healthcare professionals and their work with older people and vulnerable groups to be integrated into a system. I enjoyed the phrase about there is a lack of an enabling environment, and I think that's going to be critical going forward. So what is your takeaway message for the town hall participants today, Susmita?
I think I'll leave you with 3 takeaway messages, and it also touches upon the relevant SDGs for older people, 4, 8, 10, and 17. So first of all, I think we need a holistic approach in approaching the health system. And we have also heard this from the comments. We're not only looking at the aging populations health workers serve, but also the aging health workforce. And as I mentioned before, this is not going to be the last pandemic or the public health crisis. We'll continue to face a shortage of health workers, and we should use this opportunity to formalize the contributions of older health workers, and if need be, to create roles that are better suited to their strengths. As I think Kanchit mentioned, you know, how do we bring in the strengths? How do we do that? And finally, I think the old saying that we have, no news is good news. In this case, it's dead wrong. If we do not have data, this remains an invisible problem. We need to push for disaggregated data based on age. And this also applies to the current situation we're in. So if you don't hear from your friends, your family, or coworkers, check in on them. I think the mental impacts of this pandemic have been colossal. So we want to make sure that no one gets left behind. So let's not follow the no news is good news.
Look, that's a great takeaway message. And I'm very conscious with colleagues on the calls, you know, that we need to reach out to colleagues. And if you don't hear from them, reach out. And even if you do hear from them, reach out. Because that's going to be critical going forward. You know, because we may see that, you know, there are changes in the rate of COVID, but we're very much living in the same position as we were earlier this year. I want to acknowledge Jane Teasdale, you know, founder and CEO of Mosaic, who's put some information in the chat box. So thank you for being on the call today, Jane. And thank you, Andra and the IFA team, who are nothing short of amazing. And we thank you, Susmita, for an inspiring town hall. And we look forward to seeing you all next Friday, where we will be hearing from Dr. Jane Carmody, who was on the call today, and Mr. James Appleby. So from the John A. Harford Foundation and Gerontological Society of America. So thank you once again. Be well, stay safe, and reach out to that person that you haven't heard from for a while. See you next week. Bye-bye.
Thank you.